Now, let's start. Good morning, good afternoon, and good evening to the esteemed speakers, my colleagues, and the participants from across the globe. Today, we are here to have a webinar on IPA webinar on Patient Safety Day, which is on safe care for every newborn and child. Before going into the webinar, we'll start with the guidelines. If you have any questions for the speaker, kindly put them in the Q&A feature. To obtain the certificate of attendance, participants are required to attend the entire duration of the webinar and fill in a feedback form, which will be distributed at the end of the event. Please note that the Zoom closed captions are generated by AI, and there may be instances where the translations are incorrect or misleading. We appreciate your understanding in that. Now it's my pleasure to welcome Dr. Erkin Rahimov to give his opening remarks. Dr. Erkin Rahimov is the head of Pediatrics Department of Baku Medical Plaza Hospitals, assistant professor at Azerbaijan State Advanced Training Institute for Doctors named after Aliyah. He has also acted as advisor on the Child Mortality Committee at the Azerbaijan Ministry of Health and the Early Childhood Development Program at UNICEF. So, Dr. Erkin, the floor is yours.
Hello, everyone. I am Dr. Erkin Rahimov. I am member of the Standing Committee of IPA term 25-27 from Azerbaijan. I am pleased to welcome you to today's IPA webinar, Safe Care for Every Newborn and Child, dedicated to an incredibly important topic, patient safety. As many of you know, September 7th marks World Patient Safety Day, a day to emphasize the critical importance of safeguarding our patients' well-being. Today we are here to share insights, best practices, and innovative approach to enhance patient safety in our healthcare systems. Thank you for joining us today as we explore ways to create a safer environment for all patients around the world. In our webinar, we will have very distinguished experts in this field, and I hope it will be a very productive session for everyone. Now it's my honor to present the moderator of the webinar, Dr. Peter Lachman. Dr. Peter Lachman is an international leader in the patient safety and quality, former CEO of ISQA, and editor of 3 OUP handbooks. So, Peter, the floor is yours.
Thank you, Erkin, and thank you to IPA for hosting this meeting. Erkin and I manage or coordinate the Quality and Safety Committee that has been set up by IPA. Thank you, Joseph, for your leadership on this. And we've got an exciting session today. I was very pleased to be the editor of the patient safety goals for the year. Remember, World Patient Safety Day is the start day, not the end day. And this year, the focus, has been on newborns and young children. And we are very privileged to have this because IPA will play an important role in helping what we do. So today we have a number of speakers. We have our president, Joseph Haddad. So you'll be hearing from him. You'll be hearing from Berta Maliki from the WHO, who's our next speaker, and she'll be talking about what the WHO is doing in quality and safety, and particularly on World Patient Safety Day. And then Rajesh Mehta, who is the chair of the subgroup on quality of the three groups we have, and he'll be exploring issues again on quality and safety. So that's the day we're going to have. So the first speaker we're going to have, as I mentioned, is Berta Maliki. She's the unit head at WHO Geneva. She's worked there in a number of areas, particularly in child health and now in the safety area. And it's very pleased over the last few months, I've been working very closely with Berta and her team to develop the patient safety goals. And she'll give you an overview of patient safety and patient safety goals. And I think this is going to be a really interesting area. Just remember, please put your questions in the Q&A area. You can put things in the chat. We'll be monitoring them for afterwards and come back to them. And hopefully we'll have Q&As. So Berta, over to you.
Thank you very much. Thank you, Peter, for the warm welcome, and thank you to IPA for inviting WHO to share this year's campaign on patient safety for newborn and child health, especially pediatric care 0 to 9. As I'm trying to share now my slides, I'd like first of all to thank you, Peter, and the team from IPA that worked with us to develop this year's campaign, especially the goals that I would take a few minutes now to describe what they are. This is a very important collaboration for us. IPA is a strategic partner to WHO, especially to the Department of Maternal and Child Health. But also we are looking forward to strengthen our collaboration with IPA when it comes to quality of care and patient safety as a priority area, for the health of children, but also global health. And that is also almost like a preempt of what I am going to describe now in the next few minutes as we move forward. So first of all, patient safety and the World Patient Safety Day 2025. The World Patient Safety Day 2025 was on 17th of September. We just started the campaign. This is 1 year long, and this event today is part of this campaign. So why patient safety? What is the global context in patient safety? By now, we know that the burden of unsafe care is one of the main reasons why people do not have a good experience of care, do not benefit from the outcomes of care, and also is one of the undermining factors in terms of morbidity, mortality, and financial impact. We know today that more people die from poor quality of care than from lack of access of care. To care. And this is important because up to 10 years ago, the lack of access to care was the main driver of mortality. Today, we know that more people, in fact, about 60% of those who already are accessing services, they are losing their lives or having consequences, negative consequences, because the quality of care is not there. And within quality of care, safe care. So that aspect of patient safety and safety within the care, within quality is very important. We know that 1 in every 10 patients is harmed in healthcare. More than 3 million deaths occur annually due to unsafe care. 50% of this harm is preventable. So not only we're doing something wrong, but half of the things that most likely is happening in the health system can be preventable for one reason or another. In low and middle income countries, as many as 4 in 100 people die from unsafe care. So this is very important when it comes in terms of numbers and mortality. Now, unsafe care has a cost, in fact, a very high cost, and that is not only for high income, low income, it's globally for all countries. We know from the OECD data that high income countries, they have up to 12.6% of their total health expenditure, which is about 878 billion annually, is lost due to unsafe care. This is a huge amount, especially in these times in which priorities are shifting from health into other priorities globally, regionally, and nationally. It is important to understand that providing safe care can save money, can save lives, and so one helps the other. Indirect costs of unsafe care goes directly into reduction of poverty and increases of income loss. And lastly, but not least important, improving safety could yield a profound economic benefit that could potentially increase global economic output by 15% in the next 2 decades. And again, those are data that come from the OECD countries. As we move forward, it's important to understand, so while we understand that why safety and patient safety specifically it is important, it's important also to understand what we can do to improve patient safety. WHO has developed and issued the Global Patient Safety Action Plan 2021-2030. This global action plan provides a framework of actions that goes along 7 strategic objectives, from stewardship and leadership and advocacy to point of care, and then to solidarity and partnerships. Very importantly, under the very first strategic objective, which is under policies to eliminate avoidable harm in healthcare, we find that one of the critical activities is the organization of World Patient Safety. And within that, the World Patient Safety Day as one of key mechanisms for advocacy, for attracting attention, and then leading towards action. In the world, so from the WHO perspective and countries, we have started to celebrate the World Patient Safety Day since 2019. Each year's Patient Safety Day changes based on the priority. It responds to a priority that may come from countries. It may respond to a priority that has been identified and evidenced in literature. It may respond to a priority that we think that needs attention because it has been silent. So as you see in the last 6 years, we have gone through different aspects either of clinical conditions, target groups, or aspects of health systems. And in this year, the World Patient Safety Day is dedicated to pediatric care, to newborns and children. The theme is safe care for every newborn and every child, and the slogan is patient safety from the start. Hence, is a privilege and very important for us to discuss with IPA today and to see the role of IPA in the implementation of this year's campaign. Now, why are we focusing on pediatric and newborn care? I already provided some of the statistics and evidence on why quality and safety are important, what is their economic, social impact. But within this broader schema, there are target groups that at times they suffer more. So for this year, we wanted to align with the WHO and the World Global Health Day that was in maternal and child health and survival. Within that, we identified that pediatric and newborn care was the group that is the most affected by lack of quality and safety. So, and within that, the steering committee that leads the discussion said that this year should be, the World Patient Safety Day should be dedicated exactly to this area of work, to this area of priority, to this area that requires more attention, especially, and I'd like to underline, especially when it comes from a quality and safety perspective. So allow me to list some of the facts that we looked and we found across the literature that allows us to understand a bit better why are we focusing on pediatric and newborn care. First of all, across the literature, we've identified that adverse events that affect pediatric and newborn care are those that, no surprise, that affect in general patient safety. So we're looking at healthcare-associated infections, medications related, surgical, pulmonary, and medical technical product related. They are not very different from other target groups. However, I'd like to underline that under medical technical product related, most likely newborn and children perhaps suffer more negative consequences than other groups. So in the literature, we found that adverse events could be as high as 91.6% in pediatric intensive care. And we see over and over that the intensive care units, especially for neonatal care, they come repeatedly in front of us as areas that require attention. And then we see also that we do have adverse events in the general care settings of over 50%, so 53.8% of children may be affected by adverse events. 1 in 6 patients in pediatric ICUs experience 1 or more adverse drug events. So again, we go to medication safety and the issues behind it. The incidence is reported up to 16.7 per 1,000 patient days, with more of this to be thought to be prevented. Now, within the neonatal ICUs, so ICUs and neonatal care are very critical and important. We find that between or up to 2.4 adverse events per admissions may have been reported, and this goes about 56 to 97% of these events being preventable. So basically, almost all admissions in ICU that are suffering an adverse event normally should be prevented. Medication error rates, they range up to 35.1 per 1,000 patient days, which can go up to 77.9 per 100 medication orders. So we're looking at very important numbers in terms of magnitude, but also potentially. Rates of healthcare-acquired infections in neonatal units are estimated up to 62% per 1,000 patient days, with higher rates in low and middle income countries. Now, while this comes from an adverse events perspective, when you look at that from the perspective of mortality, vulnerable populations, and contextual factors, we know that improved quality of care can save up to 62% of preventable deaths. That is about 1 million newborn lives every year. So now you can immediately see why the magnitude and why this problem has been prioritized for this year's campaign. Among hospital-born infants, hospital-acquired infections account up to for an estimate from the best case scenario 4% to the worst case scenario 56% of all deaths in the neonatal care. And then finally, patient harm is more prevalent to children who have special medical needs and who are dependent or reliant on medical technology. So how we are using the technology to support the children and everything that happens into that moment is very important because we are creating more residents and harm than most likely what we are intending to do. So as you can see, the situation is critical from a lens of quality with a very critical focus on safety, so pediatric safety. Now, globally, a lot is happening in improving newborn and pediatric safety. So we do have now very clear goals that globally the entire humanity should and is pursuing the Sustainable Development Goals 3.2 and 3.8 that talk to child survival and UHC. The EWEC, Every Woman, Every Child, a global strategy on survive, thrive, and transform does address the need for improvement in quality and safety of newborn and children's care. So that is important. And specifically, some of the mechanisms that we have in place, like Every Woman, Every Newborn, Everywhere, that is a EWINI, for those who are initiated or familiar, that is a movement that is mainly covering low and middle income countries that are trying to address to decrease their newborn mortality in the next now by 2030, as well as Child Survival Action Plan in line with the SDGs. Those give the mechanisms, but also those give on the actions for that implementing some of these implementing or to achieve some of these objectives. Now, I know that Dr. Rajesh Mehta is part of this discussion. He's one of the authors as well as supporters of these global movements, and I'm sure he is going to talk more about it in the next few minutes. So while we do have now these all global mechanisms, we want to know, do we have the evidence? From a WHO perspective, we have built the evidence, but now the evidence needs to inform the action. So how do we move into the action if we don't go through the lenses of global guidelines and standards? In fact, from a WHO perspective, we have done a lot of work in identifying and developing quality of care standards that embrace patient safety and put safety at the center. So since 2016, we have worked across the standards for improving quality of maternal and newborn care in health facilities, and then those for improving pediatric care children and young adolescents, as well as more specific when it comes in terms of newborn care, and then with a focus on the care for small and sick newborns in health facilities. Why so? Because it was evident that the sheer number of deaths that are happening across newborn and children are not only much higher, but this is the area of work where we know what to do, exactly how to do it, but we still haven't achieved or reached that level in which we can identify the actions. So with this, as we move from the global evidence into the actions, this year we looked across the WHO guidelines and quality of care standards to identify what were those points of convergence that will directly talk to the improvement of safety in pediatric care. And by analyzing all these documents and looking across the need for action aligned with the Global Patient Safety Action Plan, we did identify 5 areas that required immediate attention under what we call the goals. Here, I would like again to stop and to thank Dr. Peter Lachman and the team. Many of them are members of IPA who helped us to develop these goals. So those goals go on the 5 areas on engaging children, parents, and families, enhancing medication safety, improve diagnostic safety, prevent healthcare-associated infections, and reduce risk for small and sick newborns. No surprises in here. These goals, they talk directly to the main reasons for causing harm, but also they consolidate what comes across all the guidelines, recommendations, and standards in what actions we can do. And that is important because these are goals for actionable implementation. So they need to go into action, not just into defining what is it, but what actions we need to pursue. These are goals that are meant to be implemented by health practitioners, health professionals in the front line, and by health facilities. But at the same time, these are kind of goals that need to be supported by all the other stakeholders who are engaged in developing, creating, supporting the health workers to do their job in the right way. So for this, allow me just to go why we're talking about goals. We could have spoken about something else, like perhaps developing a new guideline or a new standard. We find that the goals are more proactive. They call for improvement that is aligned with the theme. They do focus on high priority risk-prone or high impact interventions. So please make the links between the statement of the evidence in terms of impact, the areas of action that for which we have convergence with the clear convergence actions based on evidence. And that is the third point on actions based on existing WHO guidance. They do target where the care matters, so healthcare facilities and providers, and they are supported. So we'd like to understand how we're progressing. Therefore, we need to have outcome measures. So we have created this environment of these 5 goals that allows practitioners to take action and to improve. Now, as I said that, we did think about how do you make this type of goals more communicable, clearer, and that again, we worked with Peter and team, and then we looked clearly through the lenses of the human factors and the design around human factors on how to articulate goals that trigger action and are clear for everybody who reads them. We further adapted the human factors framework into the 6 areas that you see in front of you. So for each of these 5 goals, we've identified what are the people or what kind of people's support or skills, knowledge, attitude, training we need for these goals to be implemented. The tasks that individuals and organizations have to complete, so activities, protocols, precautions, communication, decision-making. The tools and technologies that are specific as we move more into the safety area. So checklist, job aids, equipment, digital technologies, decision support tools. The workspace environment, very often forgotten, meaning how our health facilities are organized, the layout, the amenities, the organization and flow within these spaces or workspaces. And then we move more into the organization, more the management side, so how they are governed, the policies, procedures. What is the culture that very often defines how we're using the data or not for improvement, or how we're prioritizing or not areas that require attention, especially when you look from a safety perspective. And finally, the measures. We only looked at the critical measures that have, in terms of outcome measures that are already defined and agreed upon from WHO. So with this in mind, I would show, and I'll not go one by one in each of the goals and each of the areas, but I'd like just to give an overview of that. And I hope that during the discussion, Peter will help us to respond to some of the questions that may come as they go even more in depth in terms of the guidance provided through the goals. So the goal number 1 is about engaging children, parents, and families. And this is very important. And why, you may ask why this is the first goal, why we didn't go immediately into maybe medication safety or hospital-acquired infection. It is very important because at the end, what we said, and is part of the campaign key messages, is like children are not small adults. You know, children have special needs. They have special needs that are based on their level of development or the way on how they're experiencing the different conditions, and mostly the place where they come from. Their needs are also clearly defined by where they come from, by the family and community that support them in their growth, development, and health. At the same time, we know that children, and I'm not going to discuss the part on newborn, while they should have a voice, they have an agency, they need to express themselves. It's very often that they do speak, or it's the adults, their parents, or their caregivers who speak for them on their behalf. Hence, it is very important to mitigate and to bring together these 2 parts, the provider and the children, together with their families and communities, in order for all of us to understand where they come from, to adapt the care to their local conditions, to adapt their care to their local, to their individual growth, for that to be the correct, the right, the safe care, but also to be able to follow up with any feedback that needs to come into the family, or the follow-up of treatment and care as they move back from facilities to community. Hence, engaging children, parents, and families is the first goal. We looked from the perspective of what kind of skills we need in facilities and among providers, so the training, the promotion of child-parent awareness, involving parents in hospitals committees, and for allowing parents to remain with children, with their child, especially if they are in a hospital or in a ward area. There are a number of tasks that are very specific to this, that need to go into how the communication goes. So the sharing of timely age-appropriate information, the involvement of parents and children decision-making, the inclusion of families' views in care processes, responding to their concerns, so not shut down, but respond, and we give clear, when it comes in terms especially of discharge, the summary and the follow-up of the patient or the child back home. There are a number of tools and technologies that are necessary, that are needed. We have listed a couple of them that come directly or are related to a WHO guidance. So if you see a jargon, like the WHO 5 moments rule, that is 5 moments that are important in the follow-up and in communication. The good behavior, visual resources in providing visual resources in consultation, especially for children. The use of secure IDs for all children, and age-appropriate equipment and supplies are very clear that they need to be there as part of supporting religious. Workspace environment, child-friendly spaces for care, and design separate care areas for children, make spaces accessible for all parents, implement child-specific safety measures. And on an organization perspective, safe channels for feedback and escalation. Especially we have seen from a number of activists and advocates on patient safety, or mothers who may have lost their children due to them not being heard or not being responded upon. Those are some of the issues that are clearly coming up. Therefore, safety channels for providing feedback to the family and at least getting the feedback from the family, but also giving the families an opportunity to escalate their feedback if necessary and unnecessary. Informed consent, rooming in for parents, so again, goes back to that workplace environments of child-specific safety measures that stays accessible for all parents, and co-design safety initiatives with the parents. Finally, there are a number of measurements, and I'm not going to go through them, that can be used to understand how we're progressing. Very simple one, like committees, healthcare organizations like hospital committee or board that include patient representatives, is maybe one of the very simple measures that we can adapt and use to understand how the working environment is progressing towards this goal. On medication safety, very important. Different people, different dosage. Children with different needs and different development may require further adaptation. So this is very important in relation to ensuring toxicity is correct, that they're getting the right combination of medications that is correct for their condition, but also for their context. So few things around medication literacy, training, of course, especially on reporting medication errors, educating parents on safe medication use, train health workers on pediatric dosing are some of the key activities of the people. The ones that I would like to go is, I think, from an organization, I'll not go through everything, but from an organization perspective, if you see on the right side of your screen, organization, WHO has, over the years, has issued a number of challenges. We call them challenges on patient safety. One of them is on medication without harm. Provides a large scope of how to go about ensuring that medication gets safe throughout. So those are some of the activities that one can go and dig further to identify what makes sense in your context. Indicators from a measurement perspective, a number of indicators, some of them may or may not be streamlined in our routine reporting systems. However, we think that a number of them need to be streamlined or routinely reported, and be that like percentage of children given unnecessary medicines, which maybe comes only from studies, but we have to think about them being mainly streamlined or maybe being followed through across a number of facilities to understand how we are operating, or even very basic patient safety type of indicators, like first 1% of children experiencing medication errors that normally should be reported, but we know very well that either is underreported or not reported, or if it's reported, it's not being used for improvement, but maybe it's being used for punishment instead of going to reporting and learning system that allow us to improve the practice, which should be the way forward for this type of indicators. The third one is on diagnostic safety. Again, going back to that part of the slogan, children are not small adults, knowing age-specific vital signs and presentations perform self-check to reduce cognitive bias, keep misdiagnosis in mind, second opinion for complex cases. Those are some of the aspects that we would like to see in the competency of the workforce and workforce being able to do, especially around newborn and pediatric care. The tasks, very no, for anybody who's trained in medicine or in nursing or in direct caregiving, a comprehensive age-appropriate history is like the very first point that we start. However, we know that it's not happening everywhere and all the time as it should. Following evidence-based guidelines and diagnostic pathways, use structured differential diagnosis, specialists, inconsistent lab test results. So making sure that what we are providing in terms of care is appropriate, but also is done correctly. A number of tools and technologies, which is there, they are there, and I'm not going to go through that. I'd like to move more towards now, and this one at least are on the workplace environment. Because we know very well that often diagnostic may happen, or part of lab diagnostic sits elsewhere while children may be sitting in another ward. So minimizing the distractions in diagnostic workspaces is important. Ensuring access to point of care equipment, and again, that goes back also into what are some of the main reasons and determinants of unsafe care for children. So that is important, especially when it comes to diagnostic equipment that needs to be child appropriate and age appropriate. Providing areas of work where everything can happen well, so the ventilation or lit, but also private spaces for assessment and layouts that support direct patient observation. Across all the goals, there are a few things that will not belong only to one goal, like foster a blame-free culture for reporting errors. And I did mention the previous goal, create a working environment in which we can report freely some of the indicators. We could talk about this across all goals. We have decided to highlight it in this one. But foster a blame-free culture for reporting errors or for anything that we think we most normally report is going to create more problem for us than for anybody else. This is something important. It needs to be embedded in all our organizations, organizational culture. It needs to be reflected across all disease and all problems. But when it comes to terms of newborn and child care, on measures, a few of the more standard measures. Missed or delayed diagnosis is one that we think is important, needs to be pursued. However, we know that it's one of the indicators that is in very many contexts like this is reported. Preventing healthcare associated infections. Last week we attended, there was a big conference here in Geneva on hospital-acquired infections, and they discussed a lot, not only on pediatric and neonatal care, but across all hospitals. And we know that this remains a massive problem. It's bigger when it comes in terms of children. So a number of actions are there proposed in terms of what could be some of the ways, either from a workforce perspective and tasks, or from a workplace environment and organization that needs to be addressed. So on the measures and indicators, length of stay due to hospital-acquired infection is one measure that can give us a bit more understanding of the dynamics that are happening in terms of processes in place, the standardized care, pursuit of clinical pathways that at the end they would result in avoiding hospital-acquired infection. So this is something that we are now exploring even more and understanding what it happens. Hand hygiene compliance is another big thing, especially after Ebola in many countries and COVID in everywhere in the world. That is something that we think that should be mainstream and standardized across all organizations, but still we're seeing that things are going back and people are not complying as before. On reduction of risk for small and sick newborn, I will not go into that in depth because I know that I have two leading figures in this discussion today that are dedicated their lives into the small and sick newborn. Only just to say that this is most likely the area where we must focus globally. Newborn is more than half of overall child death globally, and within newborn deaths, small and sick newborn is half of the deaths that are occurring, and almost. I think it was about 70% of those deaths are due to many conditions of lack of safety. So please look at that carefully. Now, my task for the day was to bring in forward how these goals, what these goals mean for implementation and from an IPA perspective. So what does it mean to implement the World Patient Safety Day goals? First of all, sign up on those goals. Sign up virtually, meaning there is a website. I'll put that in the chat so you can go and sign up and then say, what is it that you can do from your perspective, from an individual perspective, team perspective, health organization, policymaker, teacher, advocate, what can you do to implement these goals? And I think IPA can do a lot for that. We were very happy to see the statement that the organization issued on the day. So today for me, it will be interesting to see how you individually think that these goals can help and can be implemented in your context. Adapt these goals to your context, to services and resources, integrate them in the initiatives and work that we are already doing. Prioritize among these goals based on the greatest risk and most urgent needs. So nothing should be just taken and put it into place without thinking what will respond more to your context. Perhaps all of them respond to your context, but perhaps some of them are more relevant at this time to be prioritized and move forward. Do encourage each other to embrace them, implement them through teamwork, systems work, and supportive culture. And I'll go back into that supportive culture. We need to change the culture of our organizations if safety has to be improved across the board. Measure performance, improve by learning from practice, feedback, and innovation. Again, very important. We will not be able, we have the guidelines, we know what the good practice in general from an evidence is, but it depends on how we adapt and implement the practice in our own workplace where we can gain the most today. And that gaining means that we have to share our learnings across. If we don't share the learning, we'll not be able to improve the practice. Sustain these goals by embedding them into the routine and monitor that, and finally do share the learning best practices. So for IPA and each of the IPA members individually, this is what these goals mean. Now, if you want to turn yourself into an advocate, there are a number of things you can do about the World Patient Safety Goals this year. You can advocate for policy and regulatory actions to embed pediatric and newborn patient safety. So put them in the center of the national strategies and plans, including those that are specific to newborn and pediatric care. Build the capacities of health workers and build them in risk management, and patient safety practices. So we need to address this almost black box and unheard black box, or something that people know about it but never do something. Do build the workforce capacities of safety practices. Do strengthen the patient safety in high-risk clinical processes. So we already said what are some of the main issues, but also like for pediatric and newborn care, we'll say ICUs seem to be like the place where things have to start. Promote a strong culture of quality across healthcare organizations, strengthen the reporting and learning systems, enhance patient and family engagement, and strengthen research on patient safety and in pediatric and newborn care. These are the goals that I said you can sign up. I'll put this also in the chat. What the form looks like, it is basically you have to say, what is it that you think that you should be doing to celebrate the World Patient Safety Day? Countries do light up monuments or buildings or spaces, public spaces in orange, and it is a way to recognize the importance, but also to celebrate. It sounds like I'm only talking about problems, but in fact, I should say that to celebrate the advances we are doing and the way forward in addressing most of the issues. Thank you. This is one of the screensaviors. I'll put it in the chat. You can go into the campaign materials and adapt many of them and use them in your daily life and your daily work, especially as we are now in this very important year. So thank you very much, and over to you.
Bertha, thanks. Really, it's a really great overview of the goals, and having been intimately involved in developing the goals, I really recommend everyone download the actual documents and see them in full, because Bertha's given you the overview. Just to stress when we're doing the goals is that in the guidance, we had to keep with all WHO guidance. So you may think, oh, there's something I'd like to have had in the goals that isn't there. It's not because it wasn't important. It's that we kept to WHO guidance at all times to make sure we were keeping with what has been accepted and reviewed by WHO. And that's very important. But this is a moving target, of course. We always want to improve. But if you just look at the goals, that's your first step. for everyone is to download the goals. Now, before I introduce our next speaker, Joseph, I'm going to just say that there are two questions in the chat, but I'm not going to answer them right now. We're going to keep them for the end. So anyone else wants to put questions in the Q&As? So Ruth, an anonymous attendee, we are going to do that shortly because we're going to move on to our next speaker, Dr. Joseph Haddad from Lebanon. I'm really pleased he's our new president. So welcome to this webinar. We're really pleased to have you, Joseph. And you're going to really take us forward on where IPA stands on this very important theme. It's our opportunity this year because next year there'll be an adult theme again, overriding adult theme. So this is our year of pediatrics for the WHO, and it'll take another 5 years before they come around to us again, based on the last one. So Joseph, over to you.
Thank you very much. I'm very pleased to be and honored to be at this distinguished panel. First of all, there is nothing to say after Blerta. She has overviewed everything. What can we add? I will add two things. One is the statement of the International Pediatric Association on quality and safety. Let me tell you that IPA is aligning totally with WHO and has emphasized, and this is emphasized in our program area led by Peter and Rajesh and Erkin here. And this is very important. Just to tell you that we committed ourselves during the World Safety Day to advocate with government and our national pediatric societies in quality of pediatric care, implementing the global patient safety action, foster our partnership and networks, promote our engagement with pediatric patient, parents, and family and community, strengthen education and training of medical students, help to establish mechanisms at national and health facilities level of monitoring quality of care, which is very important, and empower our pediatrician and National Pediatric Society and our other professional organization like ICM, FIGO, COIN, ICN, etc., etc., etc. Now, moving to my slides, and it will be completely different from the quality and safety. And this is my point of view of safe live births of our children in the world. So just to remind you that IPA has 115 years of age, and we are, I think, the oldest pediatric organization, followed by the International Confederation of Midwives, who have 103 years. So we are really very, very, very old, but we don't look old, huh? Don't worry, we are very. Now we have remedies for old people. Next slide. So next slide. My view of giving a child a best start in life is prevention. Prevention, prevention, prevention. And this includes quality and safe care. Where I think that, in my opinion, and this is what I have carried during my 45 years of career, there is three kinds of prevention to give a child a best start in life, and it's mainly avoiding epigenetic changes that are actually arising in the world. It's our primary prevention to do it before conception, during pregnancy, and after birth, and I will come lightly to that. Next slide. My opinion in primary prevention is preconception and mainly adolescence. We have to have a better care and safe quality on NCDs, STDs, and mostly mental health action. We have to promote vaccines for a safe care and quality. And very important for adolescence, promote familial planning. Recently, Rwanda government has introduced familial planning to adolescent girls. And this is really a very important improvement. Next slide. And the secondary prevention is, as you might know, during pregnancy. I will not emphasize a lot. At least we have to get 4 prenatal visits during the first, second, and third trimester. This is just, we all know about that, and how can we improve this. The third, next slide. The third one is the most important one. Next slide. Dear friends and colleagues, our lives start by two phases. A phase which is called development, and unfortunately, the phase which is called accompaniment to our end or second life in the future. If we don't prevent the issues in our development during the first years of life and prevent occurring side events during this first phase of life, the accompaniment later in life will be extremely difficult. So, safe care during the development of a child and quality of care during development of child is the best way to prevent the unfortunate event that will occur later in life. And I think it's all. Thank you for your attention, and let me congratulate all of you, and especially the invitees that are here, that are many, many, many. Thank you, all of you, for accompanying us in this excellent webinar. And again, IPA is committed and aligned with WHO on every single item regarding the child, every age, everywhere. And thank you. That's all.
Thanks very much for the commitment of IPA. It's a joy to my heart to hear that IPAs and WHO are aligned, and Erkin and I are committed to having our teams together. We've got assembled a very good team to deliver on quality and safety, which leads me to our next speaker. I'm just going to ask everyone to please put questions in the chat so that we can have a good discussion after our next speaker, who is Dr. Rajesh Mehta. And I've been working with Rajesh for the last 4 years or so at IPA, and I meet him intermittently in India, where I'm off to tomorrow night. So here we only have, he's a pediatrician with much experience. He's worked with WHO in the Sero region, advisor, and he's really led the way in quality and safety in India and worldwide. So Rajesh, over to you, and maybe you tell us a bit about our plans going forward.
Thank you, Peter, and thank you, President Joseph, for setting out the big picture about IPA's work in keeping children of all age, working for them. So let me put my slides on for today, and I will actually be sharing what we have planned in terms of pediatric quality and safety for this term of this new executive who took over in 2025 of IPA. We actually started our journey in quality with IPA. IPA actually took cognizance of the fact that by 2023, when we began the last term, that more deaths in LMICs, low middle income countries, more maternal, newborn, and child deaths were happening because of poor quality of care and unsafe care, compared to the poor access to services. So during MDG phase, there was also a concern about poor access to services. But when we entered SDG phase, the countries had worked about coverage of services without paying much attention to quality. Therefore, the analysis suggested that more deaths now happen because of poor quality and not because of poor access to care. So let me brief you about what the new executive have approved in terms of the work area related to quality, better and essential medicines, and artificial intelligence. This is a big program area, and Peter was describing the big picture because IPA presently has 13 program areas in which this is one: quality, medicines, and artificial intelligence. So there are three subgroups. Peter and Erkin actually are overall responsible for the big program area, and I'll be looking after the quality and safety part going forward in this term. So the objectives of our subgroup are that we will explore the local barriers and opportunities in the countries for the national professional societies, which are our pediatric brother and sister societies, to support pediatric quality of care and patient safety initiatives. We would want to understand that how we can help them. Strengthen the understanding and capacity of national societies on existing global frameworks, tools, resources, and Berlarta actually mentioned a lot of tools and resources which are available already from WHO and other global partners. Also advocate for pediatric quality and patient safety at international and national levels, and enabling IPA would want to enable national societies to develop partnerships with the national governments and other partners, other professionals within the country. So far we have identified 5 big buckets of work during this tenure of 25-27, for which the first task given to us was that Joseph had clear, thinking that IPA should be issuing high impact statements for keeping every child and of every age everywhere. Because IPA is custodian of children, so we should be issuing statements on very critical issues. So we just heard that IPA president has formally released this IPA statement on pediatric quality and safety. So this was one of the big works which we delivered already. We also want to, understand from the national societies about their needs and priorities towards pediatric safety and quality issues. So therefore, we would do a quick survey, and we would expect that national societies would respond, and then we can, actually redesign the program of work. If there are some additional issues they want us to work with them, we will certainly consider. We are also preparing a brief learning resource. It's a self-learning guide on quality improvement. This is a primer on point of care quality improvement, the model which we had, WHO has developed. And we will be offering this as a free of cost on IPA's learning platform on the website, where pediatricians, individual pediatricians can visit and learn in a self-guided, self-paced manner. And we will organize webinars on key topics for knowledge sharing on quality and patient safety issues, and disseminate WHO technical resources and guidelines on quality improvement and patient safety. So we actually have a formal working arrangement with WHO as IPA as a partner non-state actor, and the executive committee led by Joseph and Naveen Thakkar, who is the executive director of IPA, have agreed to actually work with WHO on pediatric quality and safety. So that's a commitment, and we have already a big statement which has been released. And we would want to compile a repository of resources and tools on pediatric quality of care and patient safety on IPA web platform, so that there is easy access to member societies and individual pediatricians as well. So ready to use a big toolbox in which multiple tools and resources on quality and pediatric safety would be made available. So that's the statement. You can access this statement on the IPA website. And also we will be sending out on social media and actually would want the national societies to undertake commitment at the national level and implement what the president mentioned in terms of our commitment on pediatric quality and safety. So the webinars, actually, we want those webinars. These are popular mechanisms of spreading knowledge and awareness on these critical issues of quality of care and patient safety related to pediatric care. And also, we would want to share good practices and successful initiatives from across the countries. So going forward, we will have a series of webinars on the 3 subgroup areas of the working program area of work of IPA. And we started this last year. Actually, with Peter's help, the last term, we were able to do 7 webinars, a series of 7 webinars on pediatric quality and safety issues, and including one in September 2024, again commemorating the World Patient Safety Day. Last time the theme was improving diagnosis. So diagnostic safety was the theme. And this time we have newborn and child. Therefore, it's a continuation for IPA to keep contributing and work with WHO and partners in the countries. So these are the flyers of the 7 webinars on important topics, on models of quality of care, on implementation, experiences from LMICs. So we had some global experts coming in every webinar, and we had WHO, experts also attending and telling us about patient safety challenges and solutions to pediatric practice for quality. And a lot of country experiences. Patient safety, this was the patient safety. Last time it was Neelam Dhingra who attended, and this year we are happy to have the participation of Blarta, who is the team lead now at PHA. And we had one on measurement of quality in pediatrics. So we had one WHO and a global expert, John Fismons, who actually enlightened our audience. And finally, again, one more on pediatric patient safety. That was our last in the previous series. And today we are starting with this year's webinar. So all these webinars are actually stocked and available at this website of IPA, and you need to register once. And then every time you log in, you will have access to these webinars. So you will find all 7 webinars recording available here, and you can learn and relearn at your own convenience. So we have had a decent run of webinars last time, and we look forward to another series this time. This is the self-learning resource which I mentioned based on the WHO package on point of care quality improvement. This will be a 4-hour, 4-module course, which could be done in one go or at your own pace, staggered over a few days if you want. But it covers 4 basic steps of quality improvement, basically a problem-solving approach. And the process and the structure would be that there would be a video lecture, a case scenario-based learning module, and some exercises and feedback. And at the completion of the course, you will do a post-test, and after successful completion, you would be able to access a certificate of participation. And once you have learned this primary principles of point of care quality improvement, you can continue your journey on several other higher level courses which are available, and we can guide you to take courses which are more complex and more higher level than the basic which you will get in this 4-step course. This is the kind of catalog of resources related to pediatric quality and safety that we want to host at the IPA website. So a lot of national policies and strategies as examples of how countries have been doing this. And we are happy to report there are very many countries, based on our survey of last time, who reported that they have existing initiatives on pediatric quality and patient safety. So under these headings, we will be able to provide ready to use, ready to access technical materials, and thankfully we have access to WHO catalog, and we will be able to bring in some selected high impact tools to this web platform. And I mentioned we would want to take a survey with the national societies to understand more that what are the directions they want to take in this critical, area of pediatric quality and safety. IPA is already committed to doing no harm. We have to keep our children safe from harm in wider society as well as in our hospitals where they come and seek treatment when they are not well. And we understand newborn children are the most vulnerable, one of the most vulnerable patient population within the healthcare systems. And we are the people who are responsible for keeping them safe. So we want to work with national societies more and more, and we will try to respond to their needs as we go forward. Unfortunately, not much money or US dollars would be available. Looking at the global condition of health, global health economics, but a lot of technical support would be available through IPA in partnership with WHO and other major, partners in this field. So we have 1 million pediatricians, and Joseph leads this bunch of 1 million pediatricians across 144 countries and 176 member associations and societies in countries. And this is a big force, and we can actually make use of what WHO goals are offering us, and we would want to promote and practice the actions for pediatric quality of care and patient safety for children of all age groups, and work with governments and partners closely at the country level as well as international level. Joseph himself mentioned that we have good relations with FIGO, the OBGYN Society. We have good relationship with ICEM, the International Confederation of Midwives, and also the COIN, the neonatal nurses. So we have partners who can work together for newborn and children, and we'll be happy to undertake capacity building of future doctors. So we all pediatricians must come together and teach medical students while they are still in undergrad and postgrad pediatric programs, so that they come out prepared to be responsible for providing best quality of care and a safe care for our pediatric patients. So Blata did show us this set of standards. So it's my earnest appeal, along with the President Joseph, that let us all, as individual pediatricians, as well as national societies, commit ourselves to implement these quality standards, as well as the global patient safety goals, which have been defined for this year. We will actually try to work out, provide you more information in our series of webinars during the 2 years, and we will look forward to that it becomes a work culture in pediatric healthcare settings through our trained membership, that there is a work culture which promotes quality and patient safety as an ongoing continuous process. So we are responsible for every child, every age, everywhere, and we are also responsible for providing safe care for newborns and children. So with that, I thank you for your kind attention. We will make these presentations available to everyone who has attended this webinar. Thank you, and over to you, Peter.
Rajesh, thanks very much for giving an overview of what our work has been over the last 2 years, 3 years, and what we plan to do with your help. And Erk and I want to thank you for putting this together. It saves us a lot of time in getting this out. And now if everyone could turn their cameras on, because I'm going to start on the questions and moderate the section with Erkin, with your help. We have 3 questions in the chat, and I'm actually going to start with the second one, not the first one. The first one is about climate change, so that's very important. But the second question is about, which I'm going to just answer very quickly, and then maybe get a comment from Joseph. We've had last year we had a presentation from Trey Kofi, if I recall. She gave a talk, and she was director of the Solutions for Patient Safety. So the question is, this question is very timely, because Solutions for Patient Safety is a network of, I'm not sure how many hospitals, but just about every hospital in North America, Canada, and the USA, who commit themselves to achieving patient safety very successfully. So we had that last year. So the question is how can we collaborate with that group? So Joseph, who are the leads in the USA who maybe we could learn from them and that network?
Look, Peter and all, first of all, IPA is open to any collaboration on any item, on any issue, on any subject. And we have created those program areas that you know. And those program areas are free to connect with any network that they want or that they want to be implicated in our national and our international one. So that in Kigali, 2027 in September, you are invited to open your network and to invite them to Kigali, because in Kigali, our meeting in 10 to 12 September 2027 will be open widely to our collaborators. We will have them in our team. We will have them incorporate them in our scientific program. For the first time, IPA will open widely the scenery and the platform to our collaborators. So I invite you, Rajesh, Peter, and Erkin, to connect with all those networks that are implicated in every child, every age, everywhere, and specifically in safety of children. So we cannot do it alone. You have to come with your expertise. And for this attendee who is anonymous, and I tell him, yes, we will take into consideration this children's hospital solution. In America, they have a lot of networks, and recently I was in the AAP. I cannot tell you how much they are involved in America, but you know, America is America. AIPA is the world. So let's, I think you got my,
Yeah.
so let us see how can we do that. But the floor is open for you, Peter, Rajesh. And
Yeah.
Thank
So
you.
I thanks, Joseph. I have very good connections with Solutions for Patient Safety, because Steve Merton's a good friend of mine, and he is the group from Cincinnati that started it. We'll invite him back for one of our webinars, and we'll
Yes.
invite him to come to Kigali. I think that that'll be really important, because they've done really good work. It is upper income orientated, but you know, as you say, USA is USA. It's got lower and middle income in USA as well as upper income. So we can learn from their experience, but they need to adopt it for the world. So thanks a lot for that answer. Now I'm going to put this to Blurter, this question. So Blurter, if you can turn your camera on, please. And Joseph, you might want to comment. It's from Ruth Etzel. It's really about climate change. And Ruth has really put this emphasis on extreme weather events, and this could be flooding or droughts, or it could be earthquakes, or it could be whatever. Climate change, fire, affects health facilities particularly, and then what happens is the hospitals get damaged. How can we help protect them? Because safe water, safe facilities, safe environment is one of the key areas within the patient safety goals. Environment is one of them. So, Blurter, do you want to comment first, or Joseph, do you want to comment first? Either way.
And ladies first.
Blurter,
Ladies
you
first.
there? I can't see Blurter there.
So let me just tell you
Yeah.
something. Blurter, now, I have experienced the blast of Lebanon August 4, 2020, where I was in my hospital when the blast occurred in less than 1 kilometer
Yeah.
by flying distance, and my hospital was completely destroyed. It is unimaginable, and fortunately, there was really a big sympathy, or a big network that has been created around this hospital, and we have been really well served by the network of the Lebanese NGOs and so on. But this is a crucial and very important topic. Ruth has right, because let me tell you, it's not only the floods, it's all the environment that's actually unfortunately creating epigenetic factors that lead to more morbidity and mortality. And I wish that Ruth also will, which is also heading the program of environment, will have a lot of webinars on that issue. We need to learn from her experience too. So it's very difficult. And also the earthquake of Turkey has given us, I have been several times to Turkey after the earthquake. It's really a catastrophe. And in Syria too. So we are also facing, actually, as you may know, the Gaza situation, which is clearly here, and I highlight this very loudly. It's a genocide, and it has to stop. It has to stop. Unfortunately, this is not the case under. Hopefully, it will be resolved soon. Thank you. Over to you.
Yeah, thanks, Joseph. And I'm going to add also Sudan, which is another area that is also where the children are the most affected. Women and children are affected in Sudan and Gaza,
Yes.
and we really need to raise up the issues, because the first things that happen in these wars is they target the hospitals and healthcare facilities, and then that affects the children and women the most. So this is something we will take up. I think as a committee, we need to take this up on quality in fragiles. I don't like the word fragile states, but affected states either by human design or by nature design. It's one of our issues we need to take up. Rajesh, your hand is up.
So, yeah. So, I just wanted to point out to Ruth that IPA also has a working area, program area on environment and climate change. So we will, this program area will collaborate with them as well. And Ruth, probably if you have some resources or ideas, we could also directly approach to the other group, and we can somehow bring the forces together within IPA and outside, because climate does affect children and mothers and newborns in multiple ways. And quality patient safety sometimes gets benefit of working in adversity. Like COVID pandemic taught us about the importance of hand hygiene. And luckily that has sustained. And I now see in very poor hospital settings a bottle of hand rub between two beds, which never used to be there before the pandemic. So we learn and we improve. So I think there is a clear idea that many groups can work together, and we are happy to contribute.
That's great. Thanks. So just remember, everyone, that the programs all interlink with each other. Environment is very important for us, and climate change is important. Erkin, do you want to comment quickly before I go to the next question?
No. I also have actually a few questions. If there's time left, I will also ask my questions.
Okay. I'll come to you. I've got two questions I want to go through if the people have asked. We have Umuhawa. I'm not sure where you're from, Umuhawa Barry, but what you're really talking about is integration, the strengthened life-saving integrations like IMNCI on mentorship programs and continued trainings. These, let's handle that peer learning. So very important is about learning. How can we get this learning across? And I think that came through in Rajesh's talk, as well as in Blurt's talk, well as Joseph, is that one of the roles of the IPA is to help us learn. And what we really need to know is what you want to learn, so that we can develop programs for you and integrate them well with others. But anyone want to comment on continual learning in pediatrics and patient safety? Because it's actually the next question. I'm going to combine the two. The next question is from a young doctor from Hyderabad in India, and he's building his career in quality and safety, and he really wants to know how can he really, what practical actions should he take in order to make patient safety part of what he does every day from the start? That's my interpretation of the question in the Q&A. So this is open to all of you because you're all educators. And I'm going to start off with Joseph as the president. What actions can our young doctor do, and how can we have continual learning?
So I think I cannot give many advices because you are the experts in that. So I will leave the floor to you for this young guy, how I think that he should align from the experts that you are. I leave you the floor for that.
Okay, thanks. So just I'm going to comment. I'll be in Delhi and Pune next week, or tomorrow. I'll be coming there to a conference of a collaborative on patient safety. So if you Amar Raju, if you just email to IPA your email address, we can be in contact, and I can advise you personally as well on what you can do in India, per se, just in India. But Rogers is in India himself, so he can tell you more directly what's available.
So, it has been our endeavor in the country as well as in WHO that we should start early in medical education, nursing education, that each health worker comes out trained with the concepts of continuous quality improvement and patient safety. Unluckily, we have not paid much attention in undergrad courses for healthcare professionals. So therefore, we have to keep, training and retraining them once they complete their course and come to the field. So I agree with this young Hyderabad doctor that if they have missed to teach them about important principle of quality and safety, it is never too late. And there are several things which the healthcare worker at the cutting edge, at the forefront, can practice. IMNCI is a clear example. IMNCI, which India calls IMNCI, was introduced to standardize the care of children who fall sick with most common illnesses, which can actually cause child mortality. So if we continue to practice the standards-based care or the evidence-based protocols for diarrhea, pneumonia, for measles, and serious illness, both in newborn and children, we are already contributing to saving lives through quality of care. But at the same time, no harm happens has to be basic principle. So we have to learn how to prevent infection, how to prevent falls, fires, burns, animal bites, which are sometimes common in villages within the healthcare settings. So all of those are areas where we should look forward to that how do we keep the patient safe when they are in the patient healthcare system of our country across the settings. So a lot to learn, but of course, the young people can also teach us more that how they in their own settings how the things work. So we could do it, and learning through peer approach and experience sharing is a well-recognized quality improvement learning mechanism. The health systems should be learning from itself and from peer, health systems. So facility to facility, district to district, system to system. So all that mutual learning is clearly important and accelerates the implementation. Peter.
Yeah, so to answer it generally, my latest paper is on inserting quality and safety into the genome of healthcare workers. And how do you do that? Well, you insert it in medical school. So if it's in the genome, in the DNA of healthcare workers, then they'll be safe all the time, because that's what they do. What you do in your DNA determines what kind of person you'd be in, personality and so on. Of course, the external factors. But my belief is that we as educators need to insert the quality and factor DNA elements right into the genome, so that it's in the DNA of healthcare workers. And this is what they do. The challenge for pediatricians is that just because we like children doesn't mean we're safe. It's very difficult to be safe in this complex environment, either in the clinic or in the hospital or anywhere on the healthcare. So as pathways. So your question, the last two questions are really fantastic, because this is where we're at. Our aim is to insert quality and safety principles into the genome of the healthcare worker, be a nurse, doctor, allied professional, physio, OT, whoever. They must think quality all the time. But we've got 10 minutes left. And in this 10 minutes, it's open for more questions that might come here. But my colleague, Erkin, over to you for your questions, and we'll see if we can answer them.
First of all, I would like to thank all presenters and you, moderator Peter. It was very interesting for me to hear new information. And I have just two questions. Dr. Blurter has already mentioned some technological advancements that are being utilized to improve the patient safety. And I wanted to ask both of you, and maybe if Blurter is here also, what future innovations do you foresee? It's my first question that can help to improve the patient safety. And the second one, we are pediatrician. How can patients, especially children, be empowered to participate in their own safety and care?
Okay, Blurter, I'm going to ask you if you're ready to answer those questions, or it's going to be open to the floor. I've got some ideas, but
I would give a diplomatic answer. I think the boundary has moved, has shifted in relation to where we can gain most of our effectiveness in terms of safety and quality. And that is clearly now moving towards the technology. What you see in the goals, although it is under the label of technology, is not technology alone, as new drugs or use of digitalization, etc. It's meant as technology in a generic or general sense. Now, from the other part and from the other side, we are looking at right now broadly on patient safety. We're looking at the use of digitalization in terms of patient monitoring, follow-up of treatment, referral and cross-referral, and personalization as an area where we see massive improvements in terms of personification of the treatment and care, personalization of the treatment and care based on the individual, but also an improvement in the follow-up and quality and safety. Use of, again, of data, digitalization, and bringing that together for a faster analysis to identify where are the pitfalls or where there are improvements. That is the second part that is quite important and interesting. Going forward, we're looking a lot in understanding how most likely AI will help in standardizing care and on identifying what are the issues that AI can help more in the standardization of care. Saying that, a big caveat, nothing replaces the human factor, because it's the human factor that makes the care of quality and safe. It is that final interaction. So yes, big potential. However, don't take that big potential as the only thing. We shouldn't forget the other part. So Peter, I'll stop here. Over to you.
oh, thanks. Okay, so I'm just going to make two comments before I open to the rest. Firstly, we're moving into a new area, because a lot of healthcare is digitalized, going to be digitalized, and telehealth and telemedicine is here for us. That happened during the time of COVID, and AI has arrived. Now, AI, is it a threat or is it a help? Well, it's both. It can be a threat if we don't know how to use it, and can be a help if we know how to harness it. So in education, we're going to be using AI in education, because that's going to be very important. How we use it, we're still working out how we can use it, because just like when the internet turned up, no one knew how to use the internet. And now we know how to use the internet, more or less, I hope. But also meetings like this. Before COVID, we didn't have meetings like this as often. Now we have meetings like this more often. So we're learning how to educate virtually. We're learning how to use AI the same way. And I predict that in time, what it's going to do, and this thing about empowerment of parents, is that it's not only going to be an upper income thing, it's going to be worldwide. Parents are going to be more informed. They're going to know what happens. They're going to know what questions to ask. And that's very good, because the more informed the parents are and the more questions they ask, the safer their children will be. That's their job, to keep their children safe, to make sure that we are following things that they can't, and to challenge us. So that's so important. So to me, digital health is incredibly important. AI is very important. That's going to be the future. We have to learn how to adapt to those new changes as healthcare providers. And again, to our young doctor, just to say that, is that in the future, you'll be the ones who are using AI, and you'll be looking past the days when we didn't use AI and say, how did they manage medicine in those days, where I have now this tool? Just like right now, I used to have my Google open and ask the patients, did you go to Dr. Google? Now I'd have to ask them, did you go to Dr. AI? And see what they say. If we see them as threats, then it's a problem, because then we will not be able to harness the potential that they have. So that's the one thing I'm going to say. The second one is from the safety point of view. In COVID, there was a big move to telehealth and telemedicine without understanding the safety issues that come with it, like misdiagnosis, delayed diagnosis, not understanding how we can examine children and so on. So we're still learning that way, and we need to get that learning on board. And then the last thing I want to say is about the equity issue about this, because not everyone has access to all these tools, and particularly in the LMIC, they may not have access, but a lot of people have smartphones in the LMIC, and they may be able to jump over the upper income countries as they adopt the new technology. And I know in Rwanda, they are pretty advanced on this. So we'll be looking for that in Kigali, Joseph, to see what the LMIC countries can teach upper income countries about use of digital technologies. And I'm just going to go now jump to Rajesh, because in India, they have got very good platforms in many parts to deal with this, with digitalization and AI. Rajesh, over to you.
Yeah, sure. I agree. A lot of potential out there. Like Berta said, still we need to test and standardize, because we make it sure that it is useful and harmless. But also, Arkin's second point, involving patients and parents, which Peter mentioned a bit. Arkin, and it is good that all pediatricians must realize that if you involve parents while the child is sick, is already too late. I think patients and parents should be involved in actually manufacturing the health of the household, because health is made in the homes. So parents should be part of the health building, but when they fall sick, they should be equal partners in bringing relief to sick child. So child himself, as much as he can or she can, and informed parents who should help prevent disease, promote health, and then when the patient is sick, the child is sick, to actually contribute to healing process and make it faster and sustainable. So Arkin, good point. Parents cannot be missed out of this equation.
Okay, thanks. And I think we're coming up for our time. I'm just going to put a plug, because I'm old enough to remember the past, and I always think we forget the past. And when I was a young pediatrician, we used the concept from UNICEF of GOBI FFF. I think you remember. Yeah, and it's forgotten these days. So I'm going to end the talk with this one. It's simple. It's all prevention. It's growth monitoring, oral rehydration, breastfeeding, immunization, that's vaccination, female education, on healthcare, on safety for the children, how to save females, family spacing, and food supplementation. That GOBI FFF applies today as it did in the 1980s.
So Peter, that's IMCI. IMCI is much of that.
Yeah. So this is really where we're going to end the talk. And I want to thank our speakers. Berta, I want to thank you for bringing the WHO perspective. Joseph, I want to thank you, the IPA leadership, and to my co-workers on the patient safety and quality, Erkin and Pete and Rajesh. I want to thank you. I also want to thank our audience, but more importantly, I want to thank the IPA admin office, Arisha, who makes this all happen. We wouldn't be here without them. So I'm going to end here. I think there might be something coming at the end, but what I want to say is that everything is recorded, goes onto the IPA website. So IP admin, do you want to say and tell us what's going to happen next?
Dr. Peter Lachman, all the webinars will be uploaded on the IPA webinar module. You can access the IPA webinar module through IPA website. You just have to log in. And if you are not yet registered, you can register. It's free of cost, and you can access to all the webinars till now, which IPA has conducted. And to help us improve, you will get a feedback form. While you end the webinar, there will be an option of give feedback, and you can fill the feedback. And you can fill the feedback form, so we can improve for further. And thank you. That's all from the admin office.
Thanks a lot. And we've there's always one final question. Are they meeting to humanitarian settings to ensure safety, considering limited resources, including pediatricians? We are reaching out to everyone. And it's something that we'll really put a focus on. I'm going to answer this one as a team, is that we will want to reach particularly the resource poor areas, and how we can do that and how we can help that. And just on from Blurter's side, there's a very good series of quality in fragile, what they call fragile states, which is really states that are either resource poor or suffering from war or famine or whatever. And that's another series you could look at and have access to. But I unfortunately, we come to the end of this webinar. Anyone want one last final question? I think I've led you to where we have to go. But thank you to everyone. And we'll see you again. Our schedule will be up soon for the quality and safety ones. But join up with IPA, then you can get every week. There's 1 or 2 webinars. So join IPA's webinars learning program. That's the next step. Thank you very much, everyone, and have a good week. Bye.
Thank you.
Thank you, everyone.
everyone.
Bye. Bye, Blurter.
Thank you so much.
Is recording stopping? Yeah. Thanks. Bye.
Bye bye, Dr. Latchman.